Welcome and greetings. My name is Samar Bhaumik, and I'm used to be the professor of pediatrics in University of South Alabama and retired colonel also from United States Air Force. Since this is my first presentation in this channel, please allow me to introduce myself a little bit more. I'm in academic medicine. I was in academic medicine for more than 40 years, 20 years in military teaching hospital with pediatric residency, and another 21 years in University of South Alabama College of Medicine, a Women and Children Hospital. I was chief of the Division of Pediatric Endocrinology at Children Hospital. Now, I was also intimately involved with the pediatric board review course that was offered by LSU at New Orleans for about 10 years. And I used to teach the pediatric endocrine and the metabolic part of pediatric board review course. So I have pretty good idea the type of question that they usually ask in the exam. So without further ado, I also like to acknowledge that I pictures and the photograph that I will present in the future case presentation or my lectures, they are clearly was taken from full consent of the parents as well as complied with the university and Air Force rules and regulation. First of all, I'm going to present a case. This is an 8-year-old girl seen in your clinic for growth problem. This is rather a common problem in pediatric endocrine clinic, and the pediatrician also see this kind of patient. And according to her mother, that she has not grown much in the last 2 years, but she has been gaining a little bit more weight, and her weight is actually on 60th percentile, and the height is 115 centimeter, which is at third percentile. Blood pressure is 110/65, and her growth chart, let's review it. The growth chart clearly shows that she really has been losing ground from here to here. In 2 years of mother's history is correct, and she has also gained a little bit more weight. After reviewing the growth chart, what will be your differential diagnosis? Could it be hypothyroidism? Well, clearly her history is suggestive. She has gained more weight, but she has not growing in terms of height. So that is actually a typical presentation of hypothyroidism. What about growth hormone deficiency? Yes, growth hormone deficiency also presents same way. They might be a little bit chubby, gain a little more weight, but there is impairment of the height velocity. And Cushing syndrome also similarly similar presentation. They gain too much weight, but they don't grow very much in terms of height. But it is pretty uncommon at this age. The inflammatory bowel disease is the one which is less likely in this case because uh, they usually have problem with malnutrition. So the weight gain is not consistent with inflammatory bowel disease. So that is the one is not likely. And important clinical information that you should get. from the history is that what is her energy level? Is she too sleepy? She has a lot of cold intolerance. We know that she has been getting weight. Any history of constipation, diarrhea, headache, visual problem, and how she's doing at school, abdominal pain, and just in general, these are the important questions that need to be asked and addressed. What do you find in the physical examination? That she has a puffy face, her skin is dry, and actually it is pretty thick over the sheen of the tibia. Heart rate is 68 per minute. Breast is 10 or 2, but there is no pubic hair. Neuroexamination shows she has deep tendon replaced, which is slightly depressed and with slow relaxation phase. And neck examination actually did not reveal any goiter. Based on this physical examination, what is your diagnosis? By now, you all have got the diagnosis, and this is very consistent with the diagnosis of hypothyroidism. Hmm? So let's see that how we can verify her diagnosis. The following lab was obtained. Her CBC was normal, hemoglobin was slightly depressed, 10 grams, which can be seen in hypothyroidism because erythropoietin synthesis is T4 dependent, thyroid hormone dependent. And she has normal chemistry profile otherwise. Her free T4 is actually low, 1.1. Total T4 is low, 1.1, and normal level in that lab is 4.5 to 11.5. Free T4 is also significantly low, 0.3 ng per TL, and the reference is 0.8 to 1.9. However, her TSH is extremely high, 158, and usual level is less than 5 MIU per ml. And we did check a thyroid antibodies, which is significantly elevated. Thyroid peroxidase antibody is more than 1000, and thyroglobulin antibody is 957, and both of them are astronomically high. We also did check AM cortisol level, which was adequate. 13.5 is considered normal AM cortisol. Now, based on this lab, what is the etiology of our hypothyroidism? Clearly, it is Hashimoto's thyroiditis or autoimmune thyroiditis, and this is based on her finding of severe hypothyroidism as well as significantly elevated antithyroglobulin and antimicrosomal antibody. Why the patient does not have a goiter? We know that most of the diagnosis of Hashimoto's thyroiditis occurs around adolescent, and they present to the endocrine clinic with a goiter. And then you do the investigation, you find the autoimmune thyroiditis. However, her situation is a little bit different. She is less than 10. This patient, what we call, has juvenile autoimmune thyroiditis. Some endocrinologists also like to call the fibrotic form because the process is so aggressive that total thyroid gland is replaced by the fibrous tissue. And these are the group of patients who present with very low free T4, very high TSH, and significant problem with the growth. And this is uh, called juvenile form. And by the time they come to our clinic, actually their goiter or the thyroid is probably fibrosed. So even if you take 8 years old, 9 years old, or so forth, statistically hypothyroidism, especially in the girls, is going to be more common cause of growth retardation at this age. So hypothyroidism is the first thing that need to be addressed. because if the patient has hypothyroidism, if you do the growth hormone test, IGF-1 and IGF-BP3, that may be depressed a little bit, and so that might give you a false impression. So thyroid has to be checked before you do any significant endocrine investigation. Breast development could be physiological because she's 8, and we do know that breastfeeding at 8 is within physiological parameters. So therefore, it could be physiological. However, it could also be because of the severe hypothyroidism. We know that TSAs, FSAs, LAs, they are all glycoprotein hormone and they share the same alpha unit, subunit. In beta subunits, only one amino acid different. So sometimes there is TSAs might occupy the FSAs receptor, what we call the cross reactivity, and might give breastfeeding. And if that is the case, then once we put them on thyroxine, they will, this breast development will go away. Thank you very much.